Hello everyone. This will be part of this segment of our cardiovascular presentation on pharmacology. And this one I'm going to be talking about our prophylaxis or preventative of coronary heart disease. Basically, there are drugs that are going to lower our LDL cholesterol levels, which is the lousy cholesterol. It's the one that can cause all kinds of heart problems. Coronary artery disease, I'm going to refer to as CAD or CHD is coronary heart disease. Both of them are caused by atherosclerosis or fat buildup in our arteries, which I know we've probably already gone over. If not, you will have a lecture on that in class. And all that atherosclerosis is the thickening of the coronary arteries. Another term in your book, which I will not refer to, is ASCVD, and that's atherosclerotic cardiovascular disease. So there's a bunch of different acronyms for this, but again, for me, I'm going to be using CVD, coronary vascular disease, or more even broader term is CHD, coronary heart disease. So our prevention of this, what are we going to do? And here are just some statistics show that half of Americans, both male and female, will die of a heart attack. That is a crazy statistic. Thrust of the treatment, primary prevention of cardiac events in patients with risk factors, and we're going to talk about those risk factors. Secondary prevention of subsequent heart events in individuals who have already suffered a heart attack. And benefits of primary prevention as it refers to cholesterol reduction have been proven in a number of clinical trials. So again, education, education, education. How are we going to educate our family members, the public, and our patients so that they can prevent a heart event? And another statistic that I found is that since 1984, more women than men have died each year from heart disease, not necessarily a heart attack, but heart disease. And number that I came up with from 2016 was 610,000. So those are big, big numbers, and we need to look at that and help people. And here's just some of the trials that I found. Lipid, some of them are in your book, some are from outside. Lipid Research Clinic's coronary primary prevention trial used the drug cholestyramine or Questrin. The Helsinki Heart Study used Lopid. West of Scotland Coronary Prevention Study used one of the HMG-CoA reductase inhibitor. A lot of those are the statins, same family as Simvastatin or Zocor. These studies help reinforce the belief that patients with known risk factors, and we'll look at those in a minute. What are known risk factors for coronary heart disease? Drug therapy with what we call an anti-lipemic can reduce the occurrence of any of these events. In anti-lipemic, let's look at that. Anti is against. LIP is anything with fat in it. We need this certain amount of fat out of the blood. So that's why they refer to them as anti-lipemics. So our primary form of lipids, let's look at what they are first of all. Our triglycerides function as an energy source, but they're stored in adipose tissue. So they end up adhering to or helping lipoproteins. And so if we have too many, we're probably in trouble. Cholesterol is primarily used to make steroid hormones, cell membranes, and bile acids. Both of these are water-insoluble fats that may be bound to specialized lipid-carrying proteins called apolipoproteins. The combinations of triglycerides and cholesterol within a apolipoprotein is referred to as a lipoprotein. So, end of all of this with cholesterol and triglycerides, we end up with lipoproteins, and we know those are fat proteins. Lipoproteins transport lipids via the blood, classified according to their density and type of apolipoprotein they contain. And we're going to talk about those in just a minute. Researchers have also identified more than 250 genes that may play a role in coronary artery disease. It commonly results from combined effects of multiple genes, making it difficult to determine the impact of a specific gene that can influence a person's risk for disease. Some of the best genes linked to coronary artery disease include low-density lipoproteins, or that LDL cholesterol receptor. And LDL is a protein that removes LDL from the bloodstream. A mutation in this gene is responsible for what we call familial hypercholesterolemia, meaning all that big words mean is high cholesterol from your family genetics. Apolipoprotein E, and again, we know that the apolipoprotein, if we go back, where'd it go? Where'd it go? There it is. I'm sorry. I'm looking right at it. The apolipoprotein is what's in combination with the triglyceride and the cholesterol that's going to hook up the lipoprotein or the fat protein. So they're saying apolipoprotein E, as in Ed, mutations in this gene, commonly called ApoE, also affects levels of LDL. Apolipoprotein B, as in boy, 100, commonly called ApoB11, Apo, not an apple, but APO, is a component of LDL, and mutations of this gene allow LDL to stay in the blood longer. So again, a problem than it is supposed to, leading to high levels of LDL. By the way, we haven't talked about it yet, but LDL is the bad cholesterol. It's the one responsible for causing, in high levels, heart disease. Less common causes of reduced coronary blood flow include congenital defects, dissecting aneurysms, and other patho. So they are looking at mutations on specific genes linked to the apolipoproteins, which is going to lead to the lipoproteins. Cholesterol, we know, just as a little background, it's a component of all cell membranes and membranes of intracellular organelles. So we have to have it. A synthesis of certain hormones and bile salts, deposited in the stratum corneum of the skin, comes from dietary sources also, manufactured by cells primarily in the liver. It's required for synthesis of certain hormones such as estrogen, progesterone, and testosterone, and synthesis of bile salts, which are needed to absorb and digest dietary fats. So a little bit about the patho for atherosclerosis. We know it's fatty fibrous plaques progressively narrow the coronary artery lumina, or just the circumference of the coronary artery, reducing the volume of blood that can flow through it. So it's basically obstructing. Cholesterol can obstruct the flow of blood, which leads to myocardial ischemia. And we know if we don't have oxygen in the myocardium, we're going to have a big problem. As atherosclerosis progresses, luminal narrowing is accompanied by all kinds of vascular changes that impair the ability of the diseased vessel to dilate like it's supposed to. This causes an imbalance between myocardial oxygen, which is the muscle of the heart, supply and demand. Myocardial cells become ischemic within 10 seconds of a coronary artery occlusion. Transient ischemia means it comes and goes, causes reversible changes at the cellular and tissue levels, but it depresses myocardial function. Within several minutes, oxygen deprivation causes a shift from aerobic to anaerobic metabolism, leading to an accumulation of lactic acid and reduction of our cellular pH, because we're going to go into an acidotic state. And what do we know about aerobic metabolism? Well, we know we need oxygen. Well, aerobic metabolism is much more efficient than aerobic in that we need oxygen to generate ATP for cellular function. The combination of hypoxia, reduced ATP or energy available, and acidosis rapidly impairs left ventricular function. And we know if the left ventricle function is impaired long enough, and it can just be minutes, we have failure and we have somebody that is not compatible with life. The strength of contraction in the affected myocardial region is reduced as the fibers shorten, resulting in less force and less velocity. Wall motion is absorbed, or wall motion is not absorbed. It's abnormal, and it's abnormally constricted in the ischemic area, resulting in less blood being ejected from the heart with each contraction, if there is a contraction at all. Restoring blood flow through the coronary arteries restores aerobic metabolism and contractility. If blood flow is not restored, a myocardial infarction will result. We are using all of these fancy terms here, but think of what we are talking about. And what does MI mean? It means myocardial ischemia. And that's what we're talking about. It's ischemia from too much cholesterol. So let's look at our plasma lipoproteins. The classes of lipoproteins, there's actually 6 of them, but the 3 most important are the ones we're going to talk about. The VLDL, which are triglycerides, very low density lipoproteins. The LDL are low density lipoproteins, greatest, and it's bolded there, greatest contributor to coronary heart disease. And then our HDL are high density lipoproteins, referred to as the good cholesterol because it's believed to be cardioprotective. So how I remember this is the VLDL, its main role is to deliver triglycerides from the liver to adipose tissue and muscle. So we use those triglycerides as fuel. So triglycerides is in there, but it's kind of an afterthought. When we're talking about lipoproteins, let's really zero in on LDL and HDL. And LDL, how I remember it, I say lousy. They're the lousy ones. They're the ones that are going to hurt us. HDL are heavenly or happy. They're the ones that are going to help us with the cholesterol levels. Let's see, what do I have about LDLs? LDL goes from the liver to non-hepatic tissues, which is basically muscle and adipose tissue. And that's the problem. If your LDL is too high, it's going to adhere to all that adipose or fat tissue. HDLs carry cholesterol back, our heavenly ones, to the liver, so it promotes cholesterol removal from the adipose tissue. And that's why we need a low level of the lousy one, of LDL, and we need a high level of the HDL one. The contribution to the VLDL to coronary heart disease is unclear, but it's very clear with LDL and HDL. Okay, I'm going to stop this right now, and then we'll have a second one to talk about the medications that we need to help this whole process to prevent coronary heart disease or coronary artery disease.